And now, my goodness, it's very long too. Professor Susan Shelmerdine, sorry for my accent. Dr. Shelmerdine is an academic pediatric radiologist and honorary associate professor at the UCL Great Ormond Street Institute of Child Health in London. UK, put here, of course UK. She completed her radiology training in the UK and has undertaken 2 pediatric radiology fellowships, one at the Great Ormond Street Hospital for Children in London and the other at the Hospital for Sick Children in Toronto, Canada. After her training, she successfully completed a PhD at UCL on the topics of perinatal postmortem imaging. During her doctoral and postdoctoral research, Dr. Shelmerdine continues to be actively involved in postmortem imaging and reporting across a variety of modalities for perinatal and childhood deaths, both from a medical, forensic, and coronial standpoint. She's a member of the ESPIR task force on postmortem imaging and has delivered several lectures on the topic, including contribution to ESPIR postmortem imaging workshop. Thank you so much for being here. Doctor, the floor is yours. A big applause, please.
That's great. Good afternoon, everyone. It's a pleasure to be here today to talk to you about the ethical AI roadmap for healthcare. So, first of all, why me? Why have I been asked to talk to you today? As the kind introduction said, I am a medically qualified doctor who specializes in medical imaging, a field called radiology for those who are not in the healthcare space. What does that mean on a day-to-day basis? So this is me at work. What I do normally is report images that are of patients. So I see not the patient themselves, but pictures of them, look at the images and write a report on the diseases that I think they have and give an opinion. And I work in a children's hospital, so I specialize in looking at only images of children. Why is that relevant to AI and to healthcare? Well, I'll tell you why. If we look at, over time, all of the AI products that are regulated as a medical device for healthcare use, we see that in the United States, their FDA approval products, it is increasing time on time, year on year, the number of products that are being regulated. And of those, the vast majority, by a very, very long way, are in radiology. And of the radiology devices that use AI, less than 3% are for children. That is outstanding, considering how many we are producing and how little we are thinking about children. And you may think to yourself, well, that's the States. What about in Europe? Surely we're a lot better. Well, a radiology fellow of mine, Dr. Brendan Kelly, recently went through the 213 AI as a medical device that's regulated in Europe in radiology, and we're not much better, but a little bit. He found that from all of the public data that he could see on the internet, branding, marketing, advertising, and also some of the regulatory paperwork that was available publicly, that 2% of these products were pediatric specific, were tested, were validated, were clearly for children's use. A little bit more were for a subset of children, so maybe not all children, but certain children, say maybe newborns or adolescents. Some of them were for all patients, adults and children, and 37% were for adults only. But this isn't what I found astounding. What I find astounding is the fact that 44% of these products, almost half, it was completely unclear who they were targeting and if they were even safe for children. So even if you are a responsible, open-minded, clearly thinking about children and how this would fit into your healthcare practice, you wouldn't be able to know. So when we think about the ethics of AI and who are the winners and who are the losers, I put it to you that maybe some of our biggest losers in healthcare are children, and they make up 20% of our total population. And that's really, really sad to think that that is the case, isn't it? So why me? Why us? Why are you here in the room? What can you do? Why do I think this is important to raise? I think it's important to raise because it's not really in our collective consciousness, I don't think. I'm quite active on LinkedIn, and I follow very, very big thought leaders in this field in digital health and technology. And one of them, with over 300,000 followers, posted a poll a couple of weeks ago where they said, oh, despite advances, there are people who are underserved, which is true in this digital health. Who do you think is most neglected? And he put a poll with these features and asked people to pick one of them. And what I think is astounding is not just that there are people who are being left out or underserved populations, but children are not even being thought of. And this is someone who's like a big thought leader, and people who are following him, and over 1,000 votes, and there was only like, well, one and me, people who were saying, oh, what about the children? What about the children? Why are we not even thinking about that? So I would just like to put it to you that although, of course, we need to think about everyone, and we do need to think about those from poor socioeconomic echelons of life, and we do need to think about femtech, I'm asking you, what about PeedTech? Because this is an area that really is close to my heart, and I think it matters. Why does it matter? So I get that a lot. Why does it matter? Children are young, they're robust, they don't have the diseases. The older people have more diseases, they're going to be more of a burden on healthcare. We should be focusing on them more, which is true, but that's only for now. The truth is, we are in dire need in the NHS and in our children's healthcare provisions. I did a survey with the British Society of Paediatric Radiologists published this year, and we found that of the radiology trainees we surveyed, 1/3 of them are qualifying feeling that they weren't confident to treat children or look at children's imaging. They also didn't feel they were getting the training and curriculum requirements, and the staff that are supposed to be training them don't feel they have the time to do that. This is a bit old now, but it's still relevant. Over half of departments don't have access to pediatric patients, giving them a specialist opinion if they came in, especially if it was out of hours. So children are being left behind, and it hasn't really changed that much over time either. And when we think about the AI tools that are in practice right now or that are being developed for healthcare, they have slightly different nuances as to what they do for healthcare that I don't think necessarily meet the same needs as children. So, for example, compared to adult healthcare, there is less emphasis in children's healthcare on cancer screening. Obviously, we don't do population cancer screening in all children like we do in some adults. There are fewer patients that are children, so our waiting times may not be quite as long and the backlog may not be quite as demanding as in adult work. However, we have a workforce deficit. We have people who don't feel confident, who really want an extra pair of eyes or a bit of extra confidence in their diagnosis. We also do want to focus on safety and quality when it comes to care, especially in children, quality of our reporting diagnoses, quality of the scanning. And remember, like, children are not just small adults, okay? They're not just the same thing, but mini-sized. When it comes to scanning them, a lot of children are very fidgety, very scared. They're not going to stay still. They're not going to be compliant. What we accept as quality of imaging in them can have a huge variety because we just want to get to the diagnosis with as least trauma on these poor children as possible, not necessarily aiming for perfect, but aiming for good enough so that we can balance that care for them with a good diagnosis and safety. We also know that there are children out there who need an MRI scan, and these MRI scans can take sometimes half an hour, 45 minutes long. They can't sit still for that long, and so many of them are having sedation or a general anesthetic just to have a normal examination done, which, as you can imagine as a parent, that is quite scary, especially when you're putting someone under an anesthetic, putting them to sleep, which is not without risks, for an exam, not even for a procedure. And that exam may actually be normal, and they may not need anything more from that. But if we could speed up that scanning and make that time shorter and reduce that kind of intervention, that would be great for them. But all of these emphases and qualities and issues do mean, unfortunately, that it's harder to make AI tools for these children. So we have smaller volume data sets, we've got a wide variety of what we accept as quality. We also have a wide variety of age-related appearances. There is not just one child. As I said before, a newborn looks very different to a school-age child who looks very different to an adolescent. We also have varied protocols in practice, and that's partly due to varied training qualifications and confidence, but also children not being able to sit still or having special needs, and us having to adapt to them rather than saying, you must do this. And also, if I'm going to be skeptical, if you're going to be an industry and create a product, you want your return on investment, and it may not be super clear if you're not going to sell as many products where that's going to come from. But all of these things really do lead to a lack of health equity, a lack of thinking about what's possible and pushing the boundaries, and as a result, children are getting left behind. So one question that I was being asked a lot when I first started my AI journey was this. Doesn't a blob look the same in children and adults? Surely children do have some specific needs, but there are also many things that look the same in children as they do in adults. So why does it matter to make child-specific tools for every disease, for example? So I'm going to show you a couple of images, right? So when I first started, one of the first projects I did was looking at whether AI could detect lung nodules on CT scans of the chest. Here we have a CT scan of the chest in a child. So that is a cross-sectional image through the chest. And here we have one in an adult. They both show a blob, what we call a lung nodule. This is one in an adult, here's one in a child. And you can see they look pretty similar. They're round, they may be different sizes, but ignore that for now. But they're in this black stuff, which is the lung, and they're quite well defined. So if I had a trainee radiologist with me and I was showing them this in an adult and said, look, that's bad, pick those things up. Now I'm going to show you a scan of a child you've never seen, and pretend they've never seen a child before and say, could you pick something up? I'm sure I wouldn't need to give them hundreds and hundreds of examples. They would probably pick that up straight away because they know what it is. But AI is not the same as human, and I think a lot of the time we anthropomorphize AI and think it's doing the same thing as human eyes when it's really not, and then get surprised about why it fails and wonder, well, if you could get an AI to pick up this blob, why can't it pick up this blob? And the reason is that it's not just the blob, is it? It's the environment in which that blob sits in. For those of you who are astute, maybe budding radiologists, you'll notice there are some big differences between these two scans, even though they're both human and they're both showing a lung nodule. Look at the shape of the chest of the child. It's more rounded, whereas that in an adult is more oval. Also, please notice that the adults have a bit more fat on them. Children don't have as much fat. The other thing to notice is that children can't breathe in and hold their breath for long periods of time or follow commands necessarily, which means their lungs are not as well inflated, so the background looks a bit fuzzier and grayer, whereas the adult, it's more black because that's more air. The other thing is children can't sit still, for example. I mentioned that before. They also want to have scans with less radiation dosages. So can you see these blood vessels are less crisp, whereas in adults, they're very crisp. So there are lots and lots of differences that might not be apparent to you, but is very apparent to an AI that's analyzing images and many images and needs to learn this from scratch. And it's been shown time and time again, you cannot use adult tools and just directly apply them to children and expect them to work the same. This is a published paper by some of my colleagues in the States where they did exactly that. They took an adult AI tool for looking at nodules and they applied it for children to see how well it would perform. And whereas the sensitivity for picking up these nodules was up to 83% in adults, that was so low, less than half of that in children. You know, and without doing this and knowing this, we may not think there's such a big difference between it, because on those scans, I'm sure you can see a blob is a blob, isn't it? But not so much so in the real world when you apply these tools. And you might say, well, okay, that's a very specific example. I'm sure there are others that are more optimistic, and there are. So if we look at chest x-rays, which is one of the more commonly examined exams that we do, we see that it's still the same kind of output, but maybe with some nuance. So in this study with some South Koreans, they used an AI tool that was approved for adults, looking at chest x-rays, and applied it to a children's pediatric population. And they looked at over 2,000 chest x-rays in children, and they found the sensitivity, okay, wasn't hugely great. It was 67.2%, but they could make it higher if they said, let's exclude certain children, those under the age of 2, and also those with big hearts. And then we can say, oh, it's really accurate. Now we can use it, or we might be able to apply it. But really, when you think in real life, let's say we apply this tool to an hospital setting, and there's some junior doctor who's on a busy shift who's now going to look at this child's x-ray and is not feeling very confident in their training about it. The AI gives them an answer. Are they going to go, oh, wait a minute, is this child under 2? Does the heart look big? If so, I can use it. If not, I can't. There's a lot of processes that have to go through, and practically speaking, that's probably not really great to implement and would cause a lot of problems. And so we do need to think about not just who benefits when we think about AI implementation, but also who misses out. And I led a paper with the European Society of Paediatric Radiologists where we got international radiologists from all over the world to kind of contribute on what they've seen as real and also perceived unintended consequences of what AI might do if it was just implemented without thought in children. So I think that's really important to know and to really prepare for in advance if you're going to be doing this, and very much more so if you're working in a mixed setting where you've got children and adults as well, because then it's a bit unclear sometimes when you could use one or the other. And we have seen serious untoward incidences happening across the world when that hasn't been thought about. So given all of that, it sounds really doomy and gloomy, I know, but given all of that, what do our stakeholders actually think about it? You might think, well, maybe they just think it's too much trouble. Like, should we even engage in this if it's all of this problem? And the reverse is actually true. I led an international survey asking healthcare professionals who work in the pediatric space what they thought about using AI or the potential, if they don't use it, for radiology and imaging. And actually, most of them agreed that it had some use. Most of them agreed it would help them and that it could alert them for abnormal findings, and they were welcoming of that. And most of them disagreed that it would devalue them, take over their jobs, make them feel inferior. So they seemed more and more welcoming of this kind of process. And earlier this year, I did a big study where I invited children from across the UK to fill out a national survey on the use of AI for their own imaging in healthcare, and asked them what would they like, how do they feel about AI for their own imaging. And surprisingly, they were actually reasonably positive, but very cautious. It seemed like a lot of them had a very good idea, being digital natives, about the risks of implementing AI. But they did want to make a point that it was hugely important to prioritize accuracy. This is going back to quality of care. They didn't really feel that speed should be an essence over accuracy. They really wanted accuracy and quality to be prioritized. They really, really wanted a human in the loop and did not like the idea of an autonomous AI at all. So they really liked having a healthcare professional to reassure them, to tell them what's next, to talk to them. And interestingly, we gave them a case study where they said, okay, imagine this is for broken bones and you're going to hospital, you think you've hurt yourself. What do you think about using AI for that? And children who said they previously had broken a bone and it had been missed were 3 times more likely to want AI than children who either can't remember or said they'd never broken a bone before. Which goes to show that actually when people have errors in their healthcare, they will feel that AI could have been helpful and more could have been done for them. So that's important to know, especially in your stakeholder engagements, because not all patients are the same, not all of them think the same, and many of them will have different lived experiences which will influence what they feel about AI and how it could or could not help them. So it's important to get a range of opinions from this, because not everyone will be equally as enthusiastic or unenthusiastic. So this session is all about human actions to align with our values. What can we do? What can we think about? I think what's really important to recognize here is that it's really hard to come up with, a long list of actions that are applicable to your specific case use and also generalizable to be applicable to as many things as possible. So a lot of the time, I think a lot of these actions are really focused on the processes that have to be in place, which is why you may find some of these things somewhat applicable, but maybe somewhat not. I am currently leading a multi-society statement paper right now, led by the European Society of Children's Imaging, but also engaging with all of these other 7 societies on what we think responsible AI looks like for children's imaging and how we can be better at doing that and share some learnings and guidelines on that. So the paper itself covers 4 different areas: purchasing and regulation, implementation, how we integrate, and the PMS stands for post-market surveillance, as well as education. I'll go through them very briefly. I don't want this to be too long-winded, but in essence, when it comes to purchasing and regulation, we are advocating for better risk assessment and safety ratings. What I said at the beginning, how do we know this is safe for children? How do we know it's even intended for children? Some ideas are putting hazards, like you see on choking hazards for toys, maybe saying this isn't good for 0 to 3-year-olds, or maybe saying what age it is good for, such as movie ratings, it's good for all ages or only for those, in adolescence, for example. Having data diversity and representation when we train our models, transparency and trust, and more importantly, communication of that to people so that it's in an understandable way, so they don't feel that certain things are being hidden from them. And we've heard earlier before about cybersecurity and privacy concerns as well. When it comes to implementation, it's hugely important to work as a multidisciplinary team and make sure this is a team sport and not an individual decision. We need to consider what setting are we deploying the AI in, what problems are we trying to solve, what is the scope of practice we want the AI to help us with. Not just we need innovation, we need AI, we need to be looking like we're trendy and keeping up with the times, but specifically what do we want it to help us with, and does it actually do that? We also, as I said, need stakeholder buy-in, make sure that the experts are available in-house to identify issues and to think about what could go wrong as well as what could go well, and also have child-friendly specialists to have an active role in this so they feel engaged in it rather than this being put upon them as one extra thing for them to have to navigate and work around. And I guess we do always need to balance the risk with innovation. We want to be innovative, we want to push boundaries, but we also don't want any harm to come to the children. So safeguards, monitoring, making sure we have a process for reporting adverse incidences, both those that are technical as well as those that are clinical too. Integrating and post-market surveillance. We talked a little bit about model validity and bias as well, and we want a way to know whether or not that's changing over time or with our population. And we want to be aware whether or not our staff are de-skilling or just going with what the AI says. We heard from Payam earlier about magical thinking about the AI, and even if you say think for yourself, people probably won't think for themselves. How do we overcome that? There is some interesting work that's being done on that and many interesting ideas. Do we, for example, have a day a week where we turn the AI off so people are forced to keep thinking for themselves? Do we put in fake dummy data so every now and again we check whether people are really looking at the imaging, you know, just like they do in airports with bomb security control where they put a fake bomb in? Do we have to do that? Do we have to not just benchmark the AI but benchmark the clinicians? So every year make sure they go through a test as well as the AI being monitored to see if they're still good enough and accurate enough. There are many interesting ideas we don't know. We're still thinking about that, and how do we collaborate in a meaningful way where we don't feel our jobs are being taken over, but we also feel augmented in order to practice even better. And there is a very small point about generative AI and agentic AI. We all know it's coming, not in healthcare yet, but in our day-to-day practice and lives, you probably use it all the time. Is it only a matter of time before it's installed into healthcare, and how do we think about that proactively rather than reactively? And finally, education. Education, how do we make people more aware and understanding of what the AI can and can't do, what its limitations? Do we have to have, I mean, in my practice, we always have something called a realm meeting, which is a discrepancy meeting where we talk about things that were missed by colleagues and how we could be better. Do we need one of those discrepancy meetings for the AI and things that it misses? So we collectively build up knowledge about what it can do, what it can't do, and share that. Maybe it's great at picking up cancers, but not great at picking up infection. So when we see something that we think could be infection, do we now have to be even more alert because we know the AI could mislead us, but if we think it's cancer, we can trust it? How do we balance that? And should we have a core literacy for everybody, but then maybe specialized, enhanced literacy for those who are in more sort of senior leadership and managerial roles who have, you know, oversight of the monitoring and implementation? And also, how do we engage our patients and public in this so that they feel educated on this and they know what AI is being used and they have some ownership of it, perhaps through the process? And tackling misinformation, that's a big part of it too. What is our role as healthcare professionals in that? And I guess the most important thing we want to highlight is that this isn't a once and done thing. It's not like here's a toolbox, tick all the things as you mentioned, and then we're done and we're good and we don't have to think about it again. It's an ongoing live kind of exercise that we have to engage in. It's a fast-paced area, AI. Things are always changing. We need to constantly look at this over and over again. I don't want to make it sound like everything is a doom and gloom, but there are some exciting things that are happening in this space. So I mentioned that there was lack of data for children, but we are trying to improve that. So there's some great work happening in Harvard where they're trying to collect lots and lots of centers contributing data sets to try to create a tool that can look for misplaced lines and tubes on the intensive care units for children. There's also a European study called Primage, which is trying to create an AI tool for better prognostication of childhood cancers. And I'm sure you heard earlier this morning about the European Health Data Space, a federated platform where not just for clinical use, but also also for research, where we can gather data from multiple institutes so that we have more generalizable data to work with when developing models. And this is something that's currently in development. There are plans to create a care AI, an ethical framework that is focusing on ethical implementation of AI. So rather than development, but how do we implement that into the real world setting in an ethical way? I believe if any of you want to be stakeholders in this, they're still open and welcoming for people to contribute their knowledge to this. So do look up this paper and email the authors if you want to be part of this. I guess I love acronyms, and one of the things I was thinking about for this talk was how do I make this memorable, and how do I make people think about all the different things that go into what actions we could take. So I thought about how do we create better, more ethical AI and responsible AI, and I think it comes down to collaboration, figuring out whose responsibility it is and making sure it's everyone's responsibility and making that clear. Education, I talked about that earlier. How do we audit, monitor, ensure that things are still working and keeping up to scratch? How do we be very transparent on this and make sure that there's that trust muscle that we're building, and ensuring that it's fairness for all? As I mentioned, with children is a blind spot. So in summary, I hope today I've highlighted that children's needs and their need for innovation are lagging behind adults, and there is a need for that, and people working in that space do welcome innovative healthcare initiatives. However, the tools that we have available right now are lacking behind those of adults, and even if we want to try to understand what tools there are, it's not always very clear, because a lot of the paperwork and marketing and branding and available documentation doesn't necessarily tell you if something is safe to use in children or not. We do advocate that pediatric imaging data sets should be better represented and used for future AI tools, and also to think about the unintended consequences. We will publish this multi-society guideline paper very soon, and we hope that that will be useful for everyone. So finally, I just want to end the talk by sharing a quote that I saw recently that really touched me, and that is this one. Until the lion learns how to write, all stories will glorify the hunter. Meaning, if we have certain types of people from certain echelons of society creating the AI, using data for the AI, deciding whether or not to invest in AI in industry, and also then in power positions within healthcare who are making decisions on what AI to use, if all of those people look very similar, think similar ways, then what hope do the others who have less of a voice, who aren't representative, have? You know, if everybody here is, you know, from a certain westernized society looking at data that's available and easy to get, that's clean, that makes their model looks good, which means they get VC funding for their particular product, which means that the CEO of the hospital is going to buy that product. What does that mean for the people who aren't represented? So let's give them a voice as well. Thank you very much.
Thank you so much, Doctor. It has been a pleasure to hear you. It's impressive, amazing. The idea of the guidelines, I hope to read the paper very, very soon, and that great philosophy. And I think that we have 10 minutes, more or less. We have 10 minutes to answer your questions. Please, go ahead.
Hi, can you hear me? Great talk, Susan. Just a couple of things. Number one, kids are just small adults, aren't they? That's a lie put together by the Paediatric Industrial Complex. Other thing, what's the view of industry in this? Because that's something that you throw a sticker here, an AI industry thing, particularly in VC funded, because VCs are interested in hyperscaling and all that, and that's huge market in cancer and adult imaging. But what's their viewpoint, and what's the engagement with responsible AI in the pediatric field?
Thanks. Try not to take offense. Children are not small adults. But no, to your serious point, I think it's a blind spot for a lot of people. People aren't thinking necessarily of children, as I said. But for those who are thinking of children, and who I've highlighted this to, they do see a need for it, and they do want to do something. What I think has been a selling point, or an interesting point, is that a lot of places that have children imaging, I'll talk about imaging specifically, have adult radiologists, adult specialist radiologists who are scared of using AI tools for children. So actually, although the cases are much fewer, the fear of actually having to look at a child's X-ray without any great training is much more. So, I mean, the few people I've spoken to have said, actually, every time we try to sell a product to a hospital, they're saying, What about children? Does it do children as well? Does it do children as well? Not, and I feel this is bad, not necessarily because they care a lot about children, but because they're so scared at being the one to make that decision and they want more support on that. They're like, oh yeah, I'm fine with the lung cancer, I'm fine with the GI stuff, the gastrointestinal stuff, you know, it'd be great to have help, but actually I don't want to be left alone with a child and having to make a decision on them, even though that's fewer cases and maybe not generating as many, you know, efficiencies, but I am just petrified and I want that help. So that's been quite a big driver, I feel.
Thanks, Susie. That was really great. On a positive side of this, you touched upon briefly on the low resource setting. Not many hospitals will have the expertise you have at Great Ormond Street Hospital. Do you think also there is a benefit of training these models and making them available to places like type of expertise you have? There are not many people in the UK, right? If you can train a model, do you think there is a benefit also sort of democratizing it?
Yeah, I definitely do. I think we're not very good at training, and I do think that there's a huge amount of work we can do with education and bringing people up to a certain level, as well as augmenting them with AI as well, and also gathering some of their data sets so that we have a much more generalizable model that is applicable to them too. But I think it would be great if we approached it from a two-pronged approach, not just saying, let's take your, I'd say, non-standardized data and then trying to make something that fits, but also saying, how can you be better at getting better image quality? And then also finding an AI that enhances that and helps you, rather than just saying, don't worry about improving your quality, you stay as you are, here's an AI that helps you. I would like to see both sides come together.
Hi, thank you for the excellent talk. I have two questions. Basically, in terms of the children data, as far as the adults are concerned, we have huge amount of data, right? And also, Boss mentioned about the VC, right? Scaling up, hyperscale, all those things. So, what are the main down points here where people are not showing interest or not putting enough resources to build, children AI radiology products? So what are the two main causes? Is it because of the data, or is it because of the VC funding, or is it because of there is no, incentives for either, it could be hospital, it could be people, patients, it could be anything. So is it because of lack of incentives?
I think it's a multi-pronged approach. Like, there are a variety of reasons for that. It's harder to get the data. There's less of it available. There's such a variety of different diseases you could tackle, and many of them are quite rare diseases. There's also a lack of understanding of where the return on investment will come in, and also, a lot of healthcare systems are a little bit nervous about whether or not to adopt children's innovation and technology. They want to be really careful as well. So until we can approach many of those sides, it's going to be hard to make it happen. But I think raising the awareness and just knowing it's there and having people advocate for children and raising that question is a great first step. I think there are many things we can do as a society to at least highlight the need for it. And I think if we do that, then it will get the conversation started, yeah.
Thank you.
Some more questions? We have 10 minutes. Take this wonderful opportunity. Thank you. Okay.
So you mentioned about kind of that there's seemingly more kind of rare diseases in children, or rare presentations that you're picking up on. I guess the real challenge with that is the kind of the events that are low frequency, high impact, those ones that are very rare but also are very, very important. How do you think that we can do better with understanding those and increasing those data sets? Is there anything that we can do to increase the availability of data surrounding those events? Because obviously that's one of the key challenges to kind of building AI to predict and detect them, would be just how much data there is available.
Yeah, that's a great question. I think part of that is creating more maybe publicly open source data sets so that people can play around with the data, learn what models work and don't work. I mentioned earlier that we're trying to create federated learning platforms and data sets across Europe. The European Health Database will really help with that, where we can get data from different centers much more easily. I also think, let's not just focus on one kind of data. Multimodal data sets may also be the way to go. Maybe we don't have that many imaging, but we have the imaging, the genetics, the outcome data. Perhaps having all of that contributing to an answer could help us immensely, rather than just focusing on one particular branch of type of data. Those are the things that I think could really help. I guess, I was going to say we could try synthetic data, but I feel that is outside my scope of practice because I'm not an engineer, and I know it comes with its own challenges, and I'm sure there are people in this crowd who are far more qualified than I am to raise that and to understand that side of things. But synthetic data may be another thing as well.
Thank you for the talk. It was great. We're looking at adoption of ethical frameworks right now in detail and trying to come up with the approach we can take for a more sort of robust way of decision making around this. But my question is about the surveys that you've done with children and young people and their sort of reliance or their acceptance of the technology. I just wonder if you've done a similar work with parents and what the impression is from parents, because I feel like we aren't engaging with the public, we aren't having such a robust conversation about the use of AI in healthcare, and I feel like parents instinctively will be more protective of the use of AI in their care than the children would be. And I'm just wondering if you had any insight into that.
Yes, I do actually. During that survey, we also surveyed the parents and carers as well. And we included not just parents, but people who had parental kind of responsibilities, whether that's grandmas, aunties, uncles, as well. It's unpublished, which is why I wasn't putting it up there. But we have done, it's almost there. It's almost near submission. And what we found was actually quite interesting. We actually found that children were way more cautious about the AI than their parents were. Or carers or guardians, I should say. The guardians, the carers were far more enthusiastic about AI, trying to do something innovative that would be able to highlight deficiencies in care, whereas the children were actually more cautious. I think they're more digital natives. They use a lot of social media. They understand the dangers of privacy, cybersecurity, and I think they were more and more concerned about where their data might go than the adults were, which I thought was hugely surprising. But I mean, it may be a sample bias. The people who answered our survey were probably more enthusiastic about AI perhaps, but yeah, it's actually not what I thought.
That's really interesting.
Yeah, I will publish that soon as well, so I'll let you know.
One more question, we have 3 minutes. Yes, okay.
Hi, so it does sound like the main role that you were thinking of, the role of paediatric AI, will be to more augment generalist radiologists and DGHs to upskill them. Has there been any work on looking how well that does upskill radio? I know there's been work on, for example, neural AI, upskilling non-radiologists and radiologists to revenue radiologists. Has there been any work on that level of AI? Because it is a massive issue. I don't think people quite understand how thin the paediatric radiology component is, and actually it's a disaster. So I do wonder if that's the main area that you see the paediatric AI being then in.
Yeah, that's a great question. It almost sounds like I planted that question because I have a great answer to that. Right now, I'm running a really huge multi-reader study on fracture detection AI tools for children. So we've just finished round 1 where we've gotten different types of doctors, orthopedic surgeons, pediatricians, ED doctors, as well as radiologists and reporting radiographers, both general and specialists, to look through a subset of x-rays, 500 of them across 4 different body parts, with and without AI, to see who benefits the most, who improves the most, and not just whether or not it's accuracy, but we're also asking them to tell us their management plan, because just because you see a fracture, for example, with or without AI, doesn't mean you do anything different necessarily with it. So we finished round 1 just last week, which concluded we had 175 people partake in that across these different disciplines. Round 2 will start in January, where we will ask them to do the same thing with an AI, and the answers will hopefully come out next year. But my hypothesis is that those that are unskilled or less confident with looking at x-rays or children's x-rays specifically will benefit the most with the AI. But we haven't got any proof that that necessarily helps certain groups more than others, although in radiology, as you know, we have that with some different adult radiology studies.
Thank you. Last question. One more. 1, 2. Okay. Go ahead. Two more. One and the second. Yeah, doctor.
Hi, my name is Sahar. I'm a doctor by background, but I'm currently working as a responsible AI fellow. I guess my question is about radiology and AI-assisted analysis on a whole rather than just pediatrics. But I read an interesting paper that was published a few years ago where AI could predict self-reported race from imaging with crazy accuracy, like 99%. And I guess what that highlights is the lack of explainability that we've got with these deep learning models. Is that something that worries you in deployment? And it seems that despite this lack of explainability, we are using AI and it's growing and we're deploying it more, especially including in the National Health Service. So I guess that lack of explainability and the impacts that that might have on underserved groups, what are we doing about it, and is it something that concerns you?
Yeah, I have probably a slightly different view on explainability. I think actually trust is more the issue rather than explainability, because how the AI is working mathematically, modically, to me as a clinician matters less than knowing what the impact is on patients. And if I know that it's not causing harm and I trust it because I know that data does or doesn't matter, then I would be more likely to use that AI than necessarily knowing exactly how it's working, what it's looking at. For example, in your example, if the AI can pick up race from images, but we don't know how it's doing that, personally, I would think, okay, that's interesting, but how is that impacting my decision making and the impact on the patient downstream? I don't necessarily think, oh, that's a problem, unless it's causing unfair advantages or disadvantages to any specific group. So for me, I feel like the focus should really be on validation, outcome measures, clinical impact, rather than necessarily knowing exactly what the AI is doing. I think where that becomes more of a problem might be not just in radiology, but more in prognostication, where the AI is coming up with decisions on here's the percentage of whether this patient will die if I don't give them chemotherapy or if I give them radiotherapy. And it's using all of their clinical notes, and I don't know which part of the notes is influencing that decision, and I'm going to be taking the blame for it if I give them a treatment and then something happens to them. I think in that kind of situation where it's more opaque, then explainability might be more of an issue. But in terms of whether or not I can see there's obviously a fracture or not a fracture, or a lung cancer or not lung cancer, and the AI says there is or isn't, I find that that's probably less important to me specifically, but I'm very well aware different people have a different opinion of that.
Professor, thank you. Professor Van.
Susie, very, very quickly, in a recent discussion at GOSH, one of our colleagues, Josh Sperg, said this, and I'm paraphrasing what he said. He was saying rather than finding trying to automate or solve a problem, try to find what problem will save clinicians more time and it's easier to solve, prioritize that, and then open up time for clinicians to have more time to solve the problems which machine will struggle. I'm wondering in radiology, what is your view on that and how could it work? Because a lot of problems at the moment are picked up what seems to be interesting or we have data to solve rather than taking that as a metric.
Yeah, that's an excellent point. And I really advocate for people to think about problems first rather than what the AI can do and how it could be shoehorned into our healthcare system. And I think this is a great point about why we need to work as a team and work with senior managers and leaders in our healthcare systems. Because me as a radiologist, I only know the pipeline of the patient in my department. I don't see the bigger picture on this. I don't know what happens in the ED. I don't know what happens afterwards in the orthopedic clinic. I have a general idea, but I don't know specifically. And unless we come together and see that whole pipeline in place and understand what the processes are, we don't know which process is the bottleneck, which ones have the most likely chance of giving the patient a bad outcome or influencing their treatment plans if we don't see it in its entirety. And also, the thing that I find the most heartbreaking thing about all of this is when you don't see the process in its entirety and you focus very much on automating and optimizing a part of the pathway that actually never really needed to exist in the first place, that is really soul-destroying, isn't it? Yeah, it's really soul-destroying. And I think unless we see that, we don't know which part of that is the most important part to tackle. And that's exactly right. I totally agree.
Thank you so much.
Thanks.
I think that is finished. We will take a coffee. Thank you so much, Doc.
Thanks so much.
Thank you.